Namaskar. Welcome to this exciting and interesting era of medical genetics. Those who have enrolled for this course, I am sure there is no need to convince them about the importance and necessity of understanding basics of medical genetics and molecular vocabulary for the practice and patient care. When we think of medical genetics or really its applications for patient care in the form of clinical genetics, there are many situations like malformation syndromes, many monogenic disorders of blood, brain, bone, etc. Also reproductive genetics, DNA diagnostics, prenatal diagnosis, etc. What has seen over the last few decades is that prenatal diagnosis and cancer genetics are the two important applications which have popularized medical genetics amongst clinicians. So let us start with this first case where ultrasonography was done for routine evaluation of the baby. And by chance, you can see that the hands of the fetus are really fused, and also the head is very tall, forehead is tall. This suggests the possibility that there is syndactyly and craniosynostosis, suggesting the diagnosis of Apert syndrome. Naturally, for confirmation, amniotic fluid was collected, and from amniotic fluid, karyotype is done because chromosomal abnormalities are known to cause multiple malformations. But in this situation, because the clinical diagnosis was thought to be Apert syndrome, sequencing of gene FGFR2 was done because the mutation in this gene caused Apert syndrome. And you can see there is a single nucleotide change in this particular gene, and this is a specific diagnostic for Apert syndrome. So the diagnosis was confirmed, and the same fuse fingers, etc., have been confirmed by the postnatal examination of the baby as well as postmortem CT scan of the baby showing craniosynostosis of coronal sutures and wide open sagittal sutures as well as bony synostosis of the fingers. So the message is that confirmation of diagnosis by amniotic fluid appropriate investigations and then postnatal evaluation helps in getting accurate diagnosis, which can be helpful for not only for giving prognosis for that particular fetus but also for information regarding risk of recurrence during the next pregnancy. When we think of these investigations, it's not only these high level investigations, but the first and most preliminary thing of taking family history in the pedigree form is the first and most important thing which need to be done for patients where the clinical suspicion of a genetic disorder is thought. So in this introductory lecture, I shall show you some clinical scenarios stressing the importance of pedigree drawing and etiological diagnosis, as well as very great use of the latest genomic techniques like microarray and exome sequencing. Of course, there are a lot of things of clinical genetics which will be covered in different lectures during this course curriculum, and there are many things which I will touch upon in this lecture will be discussed in details in further talks. So when we think of chromosomal abnormalities, 1 in 500 individuals have a balanced rearrangement. That means there is no imbalance or loss or gain of genes, but one part of chromosome may be shifted to the other and vice versa. So these individuals may have bad obstetric history in the form of recurrent abortions, etc. However, clinically, usually they do not have any phenotypic abnormalities or any medical problems. The unbalanced arrangements usually of autosomes lead to intellectual disability with or without malformations, and sex chromosomal abnormalities lead to hypogonadism or various forms of ambiguous genitalia. You can see that Turner syndrome, a very important sex chromosomal abnormality, monosomy of X, usually have classical Turner stigmata in the form of increased carrying angle, short fourth metacarpal and metatarsal, etc. But many girls with Turner syndrome may not have these Turner stigmata, and hence karyotyping of all prepubertal girls with short stature is very important. Coming to the charting and interpreting pedigree, this is the first step. If you think, suspect that a disorder in concern is probably genetic in origin, or taking pedigree will give you clue that the disorder in concern is probably genetic in origin. For this diagnosis of any patient or any individual with genetic disorder is very, very important, whether even it is a stillborn child or a very acutely sick neonate who is not going to survive. And for diagnosis, even photograph, like in this case, can be give you confirmatory diagnosis where this child was not alive and the photograph showed that there is facial clefts and short middle segment. And based on this diagnosis of Roberts syndrome, during next pregnancy, ultrasonography could show long leg bones as well as oligodactyly, and better and definite prenatal diagnosis could be provided in early pregnancy. So the coming to the pedigree, drawing of a pedigree is basically collecting family history information, medical disorders in various individuals in the family and their relations to each other. So this is a basically family history, and such drawing such pedigree and collecting information in this form really helps in great way by providing clues to the diagnosis, mode of inheritance, and thinking who could be the possible carriers in the family and would need further investigations and so on. So everybody has to know how to draw pedigree and collect this family history in this particular form. Coming to this first case scenario, antenatal visit, and this lady was referred to us at 22 weeks of gestation because of anemia, which was not responding to iron. So she had microcytosis and belonging to a group where thalassemia is very common. I just said that she could be a carrier of beta thalassemia, and she says yes, she knows her brother's daughter has been recently diagnosed to have thalassemia major. So naturally, not only we could got the cause of her anemia, but the opportunity that her husband also may be carrier of beta thalassemia, and there is a risk of their child in the womb having a serious type of beta thalassemia major is there. And because the family history was not taken during first antenatal visit, this opportunity to provide genetic counseling and prenatal diagnosis to the family was lost. So the message is suspect genetic disorders and then draw a 3-generation family history. As you can see, in this case, individual first in second generation is really has a mutation but is not affected, and such type of incomplete penetrance may be there in some families. And also for all antenatal women, screening for not only for beta thalassemia, but spinal muscular atrophy and Fragile X syndrome is necessary. Consanguinity is quite common in India in different parts of the country, and we see that it's more, if the parents, if a child has a serious type of or a rare type of genetic disorder, autosomal recessive, then the possibility that the parents are consanguineous is increases. As you can see that it's 26.6%, as against parents of thalassemia major, which is a very common genetic disorder. So this type of presence of consanguinity gives a clue that the disorder may be autosomal recessive. And in this case, this particular boy was referred to us as rheumatoid arthritis, but he has similarly affected sister as well, and parents are consanguineous. So the child who or individual who is affected with genetic disorder and brings the family to the notice of that this is a particular family with genetic disorder is called proband, and is depicted by arrow and the letter P. The individual who comes for consultation for genetic counseling is called consultant. So in this case, this particular child, because of consanguinity, we thought that could be an autosomal recessive disorder. And see, look at the picture of X-ray hands. We show that the carpals are very small, shriveled, and irregular, suggesting that there is osteolysis. So this is a disorder called multifocal osteolysis with nodular arthropathy, and these nodules on the soles are seen. So this is a genetic disorder, and molecular diagnosis by sequencing of the gene is very essential. So what happens in consanguinity is that there is a common ancestor, one or two common ancestors, and if that ancestor is a carrier of a genetic disorder, then that particular mutation gets transmitted to the next generation, and at some point of time, they are both husband and wife may be carrier of the same mutation, and that's why they have a possibility of having children with that severe disorder in homozygous form. And in such consanguineous family, it's better to inform the family that further consanguineous marriages may be prevented, or at least they may be provided genetic counseling and carrier screening. This type of carrier screening can be really confirmed by pedigree in some families, pedigrees like for X-linked recessive disorders. And here, all the females who are connected to each other through the affected boys are obligate carriers. While all daughters of an affected male are also obligate carriers, but if you want to find out siblings or the mother of a child with such an X-linked recessive disorder, and if there is no family history, then you need to do investigations to find out whether these individuals are carrier or not. Coming to the beta thalassemia disorder, it's a commonest genetic disorder in India, and prenatal diagnosis is very essential to prevent recurrences, because in some families there may be recurrent 2 or 3 similarly affected children. So for prenatal diagnosis, it is important that we have the DNA mutation, which may be different in father and different in mother. So you have to do DNA mutation analysis for the child, or if the child is not alive, then the parents, and then based on that you can do prenatal diagnosis for that particular family. So identifying mutations is the first prerequisite for providing prenatal diagnosis, and many patients with autosomal recessive disorders may be compound heterozygotes. That means the mutation from father and mother are different in nature. Prenatal diagnosis, as I said, is a very important relief to the families who have a severe disorder and treatment is not available or it's very difficult. And then recurrences can be prevented by providing prenatal diagnosis. These DNA-based investigations are now available at many places. And for common disorders like thalassemia, it's a time that India should have a program for population-based screening and prevention of total eradication of thalassemia major. What we saw for thalassemia, that mutation detection is important for prenatal diagnosis. Same is true for many other genetic disorders like osteogenesis imperfecta, which has a very great genetic as well as phenotypic heterogeneity. There are more than 17 genes for osteogenesis imperfecta, and sequencing each gene one after other is practically impossible. And in such situation, this high throughput sequencing technique of next generation sequencing is very, very useful. It can sequence all genes in one go, or it can sequence the whole genome in one go. And then you can look at the data to identify which could be the disease causing mutation in that particular patient. So this is the representative diagram representing the whole genome of an individual from one cell. The pink colors are exons or coding regions, green color are introns, which are non-coding, and then the there is lot of repetitive DNA also in the genome. Next generation sequencing, as I said, is a very high throughput sequencing, and it can sequence the whole genome in one go, or it can sequence the whole exome, that means only coding regions of all genes, along with some side by nearby intronic regions, or it can sequence only important genes relevant to the phenotype, like all genes for deafness or all genes for retinitis pigmentosa and so on. So this type of sequencing of only coding regions is becoming the first tier test. So exome sequencing can be the first tier test for clinical presentations of heterogeneous nature, like intellectual disability, autism, stillbirth, sudden death, familial cancers, etc. While it's also important for those monogenic disorders where phenotype can be, we can make clinical diagnosis, but causative genes are very many, as is listed here, like osteogenesis imperfecta, retinitis pigmentosa, various types of myopathy, etc. And because these phenotypes, these disorders can affect any organ system of the body and will present to any clinician, depending on whatever the specialty may be. And hence, it's very important that every clinician knows basic principles of medical genetics and molecular vocabulary. The use of powerful technique of NGS is depicted here in this family, where the consanguineous family, two daughters died of some disorder like immunodeficiency disorder, and naturally their samples were not available. The disorders, the records were very sketchy. You can see microcephaly noted in one daughter who was seen briefly in our department, and also there was neutropenia in another child. And the family said that they do not want to go ahead with the next pregnancy unless definite prenatal diagnosis can be provided. So we decided to go ahead with the exome sequencing of the mother first, and it identified a genetic variant in NHEJ1 gene. And once you identify some variant, if you want to find out about the disease caused by that gene, you can go to OMIM, which is a free online database of all genes and genetic disorders. And here you can see that this particular disorder is the cause of immunodeficiency disorder with microcephaly. So microcephaly was documented in one daughter, and hence probably we could decide that this particular DNA variant is causative for the this disorder in this family. And such type of deep phenotyping really helps in interpretation of exome sequencing. Naturally, we told that we can provide now prenatal diagnosis because we know the cause, but there is an issue that because we haven't tested any of the daughters, so some possibility of error may be there. And hence, the intelligent husband said that they have a small piece of dried umbilical cord of one of the daughters, and we could extract DNA from that and confirm the sequence variation in homozygous form in that particular daughter. And this really was helpful to provide prenatal diagnosis during the next pregnancy of mother, and the child was normal. So such type of diagnosis, which was impossible a decade ago, has now become possible. But for all this, detailed clinical evaluation continues to play an important role for analysis of NGS data. And equally important is communication between the laboratory and clinician, and it doesn't end after sending the sample or getting the report, but after getting the report, pre-analysis or re-examination of the child, or reverse phenotyping is very, very important. As I said previously, again to stress that saving a sample of a small child or any individual who is dying or died is very important, because otherwise when we get such type of referrals that two children died of septicemia or two babies died of birth asphyxia, then we know that this is likely to be genetic disorder, but testing becomes very, very difficult, and storing sample is very important, because in this era, even if there is a single family and single child with a rare genetic disorder, you can identify the genetic cause, as shown in this particular case. We had seen a child with hand malformation, very rare type of unique type of hand malformation in 1999, and then in 2003 prenatal diagnosis and recurrence was there, same type of digits arising from the dorsum of hand. And then in 2016, when we did first exome sequencing, we could identify the causative gene BHLHA9 in this particular family. So practically each patient and each test for each patient is really research. And in this type of this particular disorder, where a specific type of hand malformation is reported on OMIM, and still the only case reported from all over world. So this is very important that each case you evaluate as if it is a research case, and then if the family can be helpful. uh, what we saw of many monogenic disorders, and in that group, an important is a group of familial cancer syndromes. And these familial cancer syndromes are inherited in monogenic form and account for 10% of all cancers. Their diagnosis or suspicion is very important because there may be possibility of recurrence in the family. And in this particular man, the pheochromocytoma and medullary thyroid cancer suggested that he has MEN2, and then the sequencing for the gene was done. The mutation T2C was identified. Naturally, the possibility that he can transfer the mutation to his offspring was there, and hence we tested all the children, and 3 or 4 are carrying the same mutation. This pre-symptomatic diagnosis of children is very important because some of the patients with MEN2 sometimes may have thyroid cancer during early childhood. Other type of familial cancer is retinoblastoma, very important for counseling, as many of them have uh, uh, family history, or many of them are bilateral, suggesting that it is an inherited form. Identifying familial cancers, the first important clue is early onset cancers and then multiple family members affected. So this hence detailed pedigree should be drawn for each patient with cancer. The NGS technique is a really very game changing in research as well as patient care, and this type of disorder where there is a mosaic form of involvement, the gene could be identified only because of NGS done from the affected area, and then NGS done from the normal tissue. So the mutation which causes the disease was present only in the affected tissue, and this causative gene was identified, AKT1. And same type of sequencing strategy is also used for cancers, because cancer tissue has some specific mutations which give the cancer tissue an advantage of overgrowth. And if the DNA data of cancer is compared with the DNA sequence data of the normal tissue of the same individual, one may identify some specific sequence variations in the genes which can be targets for therapy. And such precision oncology can be possible because of NGS-based technique. So what we thought that monogenic disorders, lot of things have changed over last 2-3 decades, and this highlights that not only diagnosis, but this correct diagnosis can lead to treatment. And this is a landmark paper in 2011. Here, the child with multiple abscesses till 15 years, 15 months of age, the cause could not be identified. So finally, next generation sequencing and exomes, the whole genome sequencing was done, which identified a mutation in a gene called inhibitor for apoptosis. So it was decided that this particular could be the cause for his disease, and then possibility of bone marrow transplantation as a possibility of treatment was considered, and he was cured with BMT. So this is an example of how bench to bedside that research can be translated for the patient care. And such type of treatments are coming over last few decades. Gaucher disease being the first where the enzyme replacement therapy was identified. And you can see that how immediately liver and spleen size decrease, as well as improvement in the hematological parameters like hemoglobin platelet count are there. And these children are getting treatment for more than 10 years and now grown up. Or also this particular lady, you may not realize also that she is a patient, but she is a patient of Gaucher disease and getting treatment for many years. Now she is married and also mother to two kids. So such type of successful stories are really very, very important and being positivity to all of us who are practicing medical genetics. Successful gene therapy, especially for spinal muscular atrophy this year, and immunodeficiency disorders, beta thalassemia. These are important landmarks for in the era of molecular genetics. Um, Not only gene therapy, but many pathway-based drugs are being developed, and you can see the efficacy of selumetinib in sort of resolution of the disfiguring plexiform neurofibroma. This another disorder which is an X-linked hypohidrotic ectodermal dysplasia. The children don't sweat. So the protein which is deficient in them could be given intraamniotically when the skin is being formed. And here you can see in the image B, this is the mouse who is affected with this particular disorder, was treated by intraamniotic infusion of the specific protein, and his even sweat glands are also normal. So same therapy was given to the these two twins, and then you can see their affected brother is the elder son, elder child, but these two children are absolutely normal because of the prenatal treatment with the deficient protein, which is infused in amniotic fluid. Though such type of treatments but raise another concern, because cost of these treatments are enormous, and many or nobody probably can afford these treatments of its own. And hence in 2021, Government of India has taken a very important decision and first important step for these rare diseases in the form of rare disease policy of India. A lot is to be done, but this one and first important step is very important. Also, the process of collecting data, facts, and figures of rare diseases have been started by ICMR as well. So, at this point of time, when you see a patient and probably do not suspect genetic disorders or do not correctly diagnose, and there is recurrence or the treatable disorder is missed, then probably it will be very, very difficult for the patient as well as for the doctor, because now a lot of things are possibilities are endless. And I hope during this particular course, you will get to know in details about diagnosis and treatment of very many genetic disorders. Thank you.